Since we are close to start time, we're going to be starting at 12:15. I like to give everybody just a few minutes at noon to collect themselves and wrap up things and get lunch if they need to. So we are, as I mentioned, recording the session today. So you're going to have all the slides and you'll have a link to the recording. So you will have that to review or share with your team. So I'll be sending that out in an email to you. If you wouldn't mind, again, if you are logged in on the computer where you can chat, please chat in your name and the name of your practice so that I can use that for attendance. If you are or have called in on the phone and you're not able to chat, just if you can send me a quick email, and that way I can know that you were on the call. And thanks to those of you who have joined us. So I am going to go ahead and get started. I believe Dr. Harris has joined us as well. So welcome everyone to the Store It Safe action period call. This is our first action period call. These are a time for all of us, all of the practices to get together and talk about some topics that will hopefully help your work on Store It Safe. We also want to thank the Ohio Department of Health. They have been a great partner to us in this work, and thank them for funding the project. So today, Dr. Emily Harris is going to introduce herself, tell you a little bit about her, and talk to you about prescribing for depression and anxiety in primary care. We know that a lot of you are doing a lot of work with mental health in a primary care setting, and she's here to provide some great education and answer questions. And then I am going to go through some aggregate data for December with you and give a few reminders. So with that, I am going to stop sharing. And let's see if I can. And Dr. Harris, you should be able to share now.
Okay, great. It has a little, there we go. Perfect.
Great. Yep, I'm seeing your screen very well. So I'll turn it over to you and I will monitor the chat box. So feel free, guys, if you need to unmute yourself and ask questions, that's totally fine. Raise your hand or chat it in the box and I will let Dr. Harris know. Thank you.
Yes, I also, if anybody knows me from Project Echo, I love seeing faces too. I know we're all eating and trying to get our lunch in, but turning your camera on, I would love it to see other people too. So, but anyway, hi, I'm Dr. Harris, and I'm a psychiatrist and pediatrician from Cincinnati Children's, but an avid fan of the Ohio AAP. So I don't have any financial disclosures, and I have reviewed my slides with consideration for the Ohio AAP's diversity, equity, and inclusion standards. And if you have any feedback for me, I welcome it. And my email address is there. It's just my first dot last name at cchmc.org. But I also recommend, or highly recommend, that if you haven't seen our diversity, equity, and inclusion toolkit, it's pretty awesome from the Ohio AAP website. So today we're going to be peeking at a really fire hose version of treating pediatric anxiety and depressive disorders, focusing on the first line pharmacotherapy, and then recognize, and you'll be able to recognize and address some of the adverse effects that can happen with these medications. So just a brief overview of what we're doing. So you have these guidances that say you need to be screening for anxiety and depression. A lot of us have been screening for depressive disorders with the PHQ-9. The recent guidelines from last year talked about adding anxiety to universal screening for all kids 8 and up. But what we have that we commonly use are the GAD-7, which is available for kids 12 and older, or validated for kids 12 and older. There's a SCARED, which is also a brief SCARED version, is validated in ages 8 and older. And it's kind of nice because the severities of the PHQ-9 and GAD-7 are relatively similar. So it makes it a little bit easier to think about, and quickly, those scales of over 15 or 16 is like considered to be severe. Anything over 10, or actually for both, anything over 10 is much more likely that they do meet criteria for mental health disorders such as anxiety or depression, depending on the scale. And then if you use the scared, the threshold score for, there's probably something there is, or possibility it's over 25, and probable anxiety disorder is over 30. But then you could even just do the subscales to see. I had a kid score like 13, but they were all in social anxiety. So I still diagnosed the social anxiety disorder after using the scared for that person. But they relatively approximate like level of severity, which is how much impairment somebody has. And that kind of predicts which part of the algorithm you start from. It doesn't mean that's where they always are, but that's where you start. And if they're not getting better, you kind of escalate and add one more thing. So medication's obviously one of those things that we think about, but actively being engaged, having CBT and therapy is kind of like a persistent theme you're going to hear about. Red flags to talk to a psychiatrist or consider consulting with a psychiatrist. It doesn't mean you have to refer them automatically, but it is very reasonable to phone a friend for different situations, depending on what your training is and what your capacity is in your practice. If you have a child that has repeated substance use or if they've used it before the age of 12, then that is a red flag that they might have substance use disorder. They have a very high risk of an addiction, and having a specialist weigh in is probably helpful. If they have disordered eating patterns on top of their mental illness, or if there's suicidality or self-injurious behavior. And this is also like
I agree. I have no concerns about the
any,
ones
I think
that are
somebody's
too much
unmuted. But if there's any repetitive
family
thoughts or
got
behaviors.
here.
Yeah, I'm sorry.
But they could even acknowledge that.
I've been trying to go through and mute folks, but can you please make sure you're muted?
Yeah.
Stronger in some areas
If everybody can mute, that would
so
be
they seem
helpful.
pretty reassured.
Oh no.
Passing wise, they have weaned it
I'm
off
gonna
during the
mute
day, so it's
everybody
the
just
sleep
for
kind
one
of
moment and then
problem
I'll
solves how you start
unmute
to
you,
make that
Dr.
transition.
Harris.
Okay. All right. Look at those magic
There
co-host
we
skills.
go. I'm sorry,
Thank
I
you.
had to go like really savage and just mute
Yeah.
everybody. Thank you.
Yeah, no, it's okay. It happens, like it happens to me too. So repetitive thoughts or behaviors, so like OCD, autism can present this way. It has like, I also added in there considering if their repetitive thoughts or behaviors are related to like an intrusive or a flashback or something like that. I think sometimes even trauma, and that would be a reason to just make sure that you're not missing one of the bigger picture things that you need to be thinking about. Family history of bipolar disorder, and looking for symptoms and signs of psychosis or mania. And we think about like people who are responding to the internal or the stimulation that, is specifically auditory hallucinations are more specific. There's like a certain kind, but don't worry about it. If they're responding to hallucinations, that's a concern. Or if there's like delusions or thinking like what I call like depersonalization, like I'm not real, or things around me aren't real. These are things that are indicative of other conditions. And if they have a decreased need for sleep with pressured speech and like an intense either euphoria or rage in kids that lasts for several hours a day, then that would be a high concern for bipolar disorder, especially if it's episodic. If it's like that all the time, it's different. It's not bipolar disorder, but if it's like there's sudden shift from baseline, then that's really concerning. Or if they have like disorganized thinking or behaviors, that could be related to substance use. It could also be related to an underlying early psychosis. All right, so what are our best interventions? For most 98% of pediatric mental health conditions you're going to treat in primary care, cognitive behavioral therapy is the gold standard, and it actually has the best evidence for ages 6 and older to treat, mild to moderate, but even severe, but it's really the first line for mild to moderate pediatric anxiety disorders. And it is the first line along with interpersonal therapy. So we have CBT and interpersonal therapy for adolescents is first line for mild to moderate depressive disorders. So there's more options, but these have the best evidence. The core piece with anxiety is avoidance, which makes it hard to detect, but that's a whole other topic. And then the core piece with depression is like withdrawal or pulling away. And so the behavioral activation is the key way to focus the energy, if that makes sense. So the other piece is that medications, they're also really effective for anxiety and depression and pediatric disorders. And they treat both. It's like easier than ADHD in my opinion, because these medications, you don't have too many that you have to pick from, and they work on both. So you can just focus on just a couple of them that I'm going to talk about today in about 2 seconds. But when you combine medication, sometimes you have to do medication first to get them to the therapy. But once you combine the medication to get the neuroplasticity happening, the therapy piece is what actually paves the new pathways, so they get them into the healthier thinking again. But putting them both together for anything like moderate or severe is appropriate for any of the pediatric mental health conditions like anxiety and depressive disorders, I mean. But there's also like risks of not treating, because especially with social emotional development, anxiety is very powerful to pull to avoid certain conflict, avoid conversations, avoid, and you don't get those developmental milestones, as well as you're also kind of prolonging this exposure to stressful hormones and this like toxic stress. Again, that's a whole different topic. But, so when you're the medical manager as a pediatrician, you don't have to just do medications. There are different steps that you can do before you even get there in terms of the evidence-based interventions available. But highlighting strengths is amazing. Even when you're doing medication, that's still important to highlight strengths. Make sure that the family understands what we're doing and that everybody's on the same page with goals. Giving the kid some ways to manage either understand what they're going through or how to help themselves like work through what they're going through is like a self-management skill that we can do. And then we have the experts that can do the evidence-based psychotherapy like the CBT or IPT, and then the medication like primary care, we can get the medication started. We can kind of get to a place, and if we need help, we can call. And then if the person's really not doing well, if they have those red flags and things aren't working out, we can have them go to the specialist for it. But the therapist actually can do a lot of that work. And if we can get it early enough, the mild to moderate, before it gets to severe, that's when the CBT works the best for these kids. So it's great that we're able to get it before it hits that point of crisis. So if you're considering medication, so for anxiety and depression, not just depression, think about functioning, and it's how much is this disorder impacting your life? So is it impacting your ability to get to school? Is it impacting your sleeping? Is it impacting your irritability is like messing with all of your friends and family relationships? When are these things happening? That kind of leads to how much severity is there. You can also use the screening tools to help with severity if you trust that the kid is has enough insight to fill it out accurately. You know, if you're thinking about it, if the family doesn't have access to therapy right away, or there's like barriers to attending, like social anxiety is a huge barrier, the kid doesn't want to go, that's not a time to think about medication. If they've had a significant course of CBT, like 4 to 6 sessions, or the therapist is like, they're not getting better or we're plateauing, that's a time to think about adding medication to it. So that would be that stepped up care. My goodness. Or if there's something comorbid like anxiety and depression or panic disorder, to think about adding medication. These are the FDA medications that are approved in kids for SSRIs or antidepressants, really. Escitalopram, which is Lexapro, is you know, for kids older than 12 for depression, and you'll see the Prozac, fluoxetine, and sertraline are FDA approved for OCD down to the age of 6. So we use this as a proxy, and it's like an off-label use to use it for anxiety or generalized anxiety or social anxiety, but it is deemed to be safe and efficacious for kids down to the age of 6, which is important to know. So like if they are very severe, especially for the OCD kids, but if they're very severe, it's okay to think about a medication because it'll help the brain like have that neuroplasticity and like get those hardwired anxious pathways to settle down. And that's really the goal, that you need to have it settle down so you can do the therapy and get the thoughts to be different. The only FDA approved medication is an SNRI, which is duloxetine or Cymbalta. And it's not first line because of the side effect profile with it. And it tends to be helpful in certain populations, but it's very difficult if you like miss a dose or if you need to wean off of the medication. It can be harder. So it's not our first line, it's not even our second line. It could be, but it's really like a third line medication if we talk about like the most effective way to manage pediatric anxiety disorders. Paroxetine is, oh, I'm sorry. Where did it go? Fluvoxamine is FDA approved for OCD down to the age of 8. That one also has a little bit more of a side effect profile to older medication. And we tend to typically just use that one for OCD, but it can be effective in anxiety disorders as well. It's kind of like a spectrum of anxiety in my head. So here it is, nitty gritty stuff. Fluoxetine or Prozac is first line pharmacotherapy for major depressive disorder in kids 8 and older. And it's also FDA approved. Actually, we can even use it younger. But it's also the first line for generalized anxiety disorders or social anxiety as well. And if they have both, I would definitely use fluoxetine first, unless there's a history of bipolar disorder or a family, strong family preference not to, like a first-degree relative had a really bad reaction to fluoxetine, then that would be a reason to try a different medication first. But even kids that are having trouble sleeping, I would still give fluoxetine, but give it in the morning. It can have an activating effect, but it's not like a big one. It just kind of makes it harder to fall asleep sometimes for some people, especially after a dose change. But if they're like looking at the dosing, for kids that are young or have or you're using it for anxiety, I start with the lowest possible dose, like 5 milligrams. And then move up gently with it every 1 to 2 weeks at the beginning until I get to a therapeutic dose. And then after that, it's every 4 weeks. And that's because it takes 4 weeks for the receptors to reset. So you'll kind of get the maximum benefit after 4 weeks at that dose. And you're really not going to see much more improvement one way or the other. It might a little bit, but not enough. That's why we do the monthly follow-ups. But to look at the ranges. So for major depressive disorder, typical range of therapeutic effect is 20 to 40 milligrams. And that is like at a minimum 20 milligrams. But if they can tolerate more, you give more. And it's not based on weight. It's not based on age. But if it's based on tolerance of it. And if they get to 40 milligrams, then that's like the optimized medication trial for fluoxetine. If we're talking about OCD or generalized anxiety disorder, you could push it even a little bit further into 40 or 60 milligrams is like that top dose, if whatever they're able to tolerate. And then we'll talk about like treatment failure after this, but it could be mildly activating. I talked about that. It also interacts somewhat with the stimulants. The way the pharmacogenetics, which is a whole different topic, but it interacts with some of the amphetamine-based stimulants especially, but it just makes their side effects worse. So you can just be conscious of that, like if they're starting to have more appetite issues or belly pain or headaches or weight loss, when you add Prozac, it's probably the stimulant that needs to be adjusted, especially, okay. Oops. And the other two, so there's only 3, Prozac, Lexapro, Zoloft, or fluoxetine, escitalopram, or sertraline. These are the only 3 you need to know. So the escitalopram, I think about like for depression, in older adolescent kids, 12 and up, you can use it for generalized anxiety disorder as well. This is so easy with dosing. It's like 5, 10, 15, or 20. And if you get to 10, the kids kind of plateaus. You can still go to 20 for the kids. Just think about if they're getting better or not, or if their symptoms have totally remitted or not. Has a pretty low side effect profile, which is nice. Sertraline is FDA approved down to the age of 6 for OCD, and we use it off label for depression and more so with like generalized anxiety and panic, or even PMDD. So those teenage girls that have that dysphoric disorder that is dangerously impulsively emotional. We think about an off-label use. It's used in adults for that, but it would be off-label in kids. But consider sertraline. Is there stuff in the chat? I just looked down, there's like 17 things. Let me know if there's anything that is related to what I'm talking about so I can stop.
Yeah, I don't think there's just been a comment. Lots of it is people joining and chatting in
Okay.
their names, but
Perfect.
Dr. Denny did say, I think it was the previous slide and probably this one too, are very helpful. So thank you for those.
Okay, great. And for sertraline, you want to get for pre-pubertal kids, like really like the 6 to 8, like that really early young childhood age. We think about like 37.5 or 50 milligrams is like a decent dose of the medication. But please know that even if you're 6, 200, if you're able to tolerate it, is still the goal for maximum tolerated dose. And especially when you're treating anxiety, you want to treat it till it's gone, is the goal, not better, because kids with anxiety don't know what it means to have to be normal or in terms of anxiety levels. So they're always going to say they're better. It's part of the disorder, but you want to make sure the functioning problems are gone when you're thinking about, do I need to adjust the medication or not? So if they're still unable to get to school, if they're still having panic, if they're still unable to get to therapy, or they can't work through the CBT pieces that they need to, then think about adjusting the medication again. Don't have them sit on a low dose because they're fine. That's like not helpful for them or the whole process of treating the disorder. So you want to get it to remission as quickly as you can, but you have to start real tiny with sertraline, or actually all the medications with anxiety, because they feel all the side effects more. It's part of the disorder. They don't know when to turn off, is this dangerous or not? So everything is dangerous. So any change they're going to notice. So you have to prep kids. Hey, this might make your stomach feel a little bit bubbly. Like when it's not dangerous. If it's, it should go away in like 4 or 5 days. If it doesn't, let me know. It shouldn't cause vomiting. It shouldn't cause fever. It shouldn't cause explosive diarrhea. It shouldn't cause like a lot of the things that are related to infectious disease. However, if you are on a dose for a long time and you suddenly stop it, about a day or 2 later, you're going to feel like you have the flu. You look terrible when you suddenly stop a giant dose of Zoloft. So that's a medication that you want to kind of give kids a warning to. Or if they come into your office with like no fever, but they look terrible, it's like, have you been taking your medication? Is a very legitimate question, because that can happen with Zoloft. And if there's more questions about that, we can go there, but I have a couple of examples. This at the top is about I got this actually from the AAP's Mental Health Care for Children and Adolescents textbook, and it's down here, the little reference to it. But it kind of categorizes the SSRIs that you commonly use. So fluoxetine, sertraline, escitalopram, and then the SNRIs, like what are the common adverse effects? What I wanted to highlight here is that activation can happen a couple of days, like with 1 or 2 days of making a dose change. Usually happens in the younger kids where they look like they have ADHD, or they're like suddenly disinhibited, they're like really silly, or they're kind of grouchy. You want to dial it down. You can either decrease the dose, go slower, or change to a different medication. That's the whole point of starting slow and low with these medications, is to watch for this activation. When the activation, so if you change a dose, let's say you go from like 75 of sertraline to 100, and it's in like an 11-year-old kid. And then suddenly, like 3 weeks later, they're kind of angry. They're having trouble sleeping. They're just like, it's getting worse. And you think, okay, it's getting worse 3 to 4 weeks after I made the dose change. That's more likely a manic activation of the medication. So going up higher would make that worse. So even though you think it's like the breakthrough symptoms, think about like the intensity of it. And is it different than your target symptoms that you were starting with? And then cut back. Actually, I would cut back very quickly on it and stop SSRIs, phone a friend, and they can help you stop the SSRI, especially if it's Zoloft. But that would be more of a sign of manic activation. And you have to kind of get different approach on board. You can still use SSRIs, but I wouldn't do it without a psychiatrist. All right. So obviously, suicidality, you want the parents to call you or the kid to reach out, use their top 3, like take a look at the Store It Safe stuff. I love their safety plan of, you know, who are you going to talk to? What are you going to do? How are you going to like restrict their access to lethal means? These pieces are all tied into just keeping a kid safe while they're mentally like vulnerable to make poor judgment decisions. And if the other piece is if they have like new self-destructive behavior, like I was talking about, especially like a month after they started or do a dose change, that's important. Or involuntary restlessness, like pacing or fidgeting, that just kind of usually ramps up at night, but it can happen. Usually this happens when there's other medications on board that force the serotonin too high. But it's called akathisia. It's really, really rare, but it can happen as well. But that's a reason that the family should let you know if these things are happening. Right. And then the other piece we talked about, like the activation is days after the dose change. You just want to dial it down or change it. But if it's happening like about a month after the dose change, like pressured speech, unrealistic plans, they can't stop moving, they're talking a mile a minute, you walk in the room, you feel stressed out all of a sudden, you need to take them off the serotonin medication quickly as possible. Call a psychiatrist if you don't know how to do that. Because the kid's going to be uncomfortable too. So this is some practical things about dosing for medication. Zoloft in particular, Prozac and Lexapro, it's a very similar pacing, but thinking about like the smallest tab is 25 for sertraline. So you can break those in half. It also comes in liquid. The liquid is really gross, but the kids with anxiety often cannot swallow pills. Sertraline, I think, is no bigger than the length of your, or the width of your fingernail. It's like super tiny, flat. It's easy to swallow, but anxiety disorders are real and swallowing pills are hard. Starting with a liquid, usually by 4 weeks into your dosing, the kid is like, I'm ready for the pill because their anxiety is better and they don't want to keep taking the liquid because it's nasty. But they'll see the benefit of the medication. The parents will see the benefits. That's why you can switch and keep going with the tab form at that point. But that being said, starting with a half tab for about a week, you can do 2 weeks if they're super tiny, but then going up to a whole tab. And then you want to see them, you give their phone call, like to check in on progress, but then you see them back in about 4 to 5 weeks to see how they're tolerating it. And then you could even go up again to 37.5. So this is a kid that has like panic or they're really impaired. I would go faster, like every week. I would increase it by a half tablet. But if they're like that's kind of the fastest I would go with it. And then seeing them back, and you want to see them back again at like 37 or 50 if they're young. If they're older, you can, we're going to get to that in a second, but you want to see if you want to stop at 50 if they're little, or 37, or you can also stop at 75 or 100. You just kind of think about it. You stop only for 4 weeks and you reassess. If they're not improved, or if their impairments are still fairly impairing, you want to go up to the next dose and don't stop until you get to 200. So for kids that are really like rigid, or it's like working, but they feel a lot better, but they're still having impairment or functional impairment, then you need to keep going with the medication. For after puberty, or again, as I was saying, for panic, you want to go up faster. So for panic disorder, that's the time where you want to get that serotonin on board to help turn off that like cortisol thing that's happening, and not turn it off, but turn it down. So you can start with the 12, but you want to go up every week, and you can call them in like 2 weeks or so to see how they're doing, but make sure that the family is increasing it until the panic goes away. And then you can hold on to that dose for about 4 weeks to decide if you need to go up or not, or if you can stay there, if that makes sense. So, and you want to go, especially for anxiety disorders, you want to keep moving until the symptoms remit and stay remitted for 4 weeks. And that's just they're going to have the thoughts, like that's okay to still have thoughts, what the CBT helps with, but the functional impairments should be gone. And this is like another way to just do a rapid titration on a kid that's older. This is often how we do it in the hospital, either 25 or 50 they start, and go straight to 100 if the kid is doing okay after a day or two in the hospital. On the outpatient side, it would be more like a week and then go to 100. To take it off quickly, decreasing by 50% every 1 or 2 days. This is a kid that looks like they're having manic activation. This is how I would stop it, while I'm also adding a medication to help with mood stabilization. So that's when you call the psychiatrist. So reasons to adjust, we talked about functioning is still impaired. The goal is to maximally or have maximal symptom remission. So they should be sleeping, they should feel refreshed, they shouldn't be angry, they shouldn't be taking a nap after school because they're so exhausted. They should be able to do those exposures that's happening in therapy, and kind of moving forward and like thinking about those cognitions and like retraining the brain on how to handle stress. And I just hit this activation and mania thing a couple more times, so this is important. But also, you monitor monthly, you want to optimize the dose, and do not let the family decide if the anxiety is better. That is up to the clinician to assess if it's getting better or not, because any little tiny, oh my gosh, that's not constant distress, is going to feel better. And I've had kids say, oh, I'm sleeping so much better because they're sleeping 5 hours instead of 3. And they're like, oh, that's great. And they also want to please you as the clinician who's prescribing. So they will more likely say, yes, that's fine now. We don't need to worry about it because anxiety does not want you to see a problem. So they'll minimize their distress. You have to ask very specific questions with, especially with social anxiety disorder, but with generalized anxiety disorder as well. Use a screening tool. Focus on the quantity of functioning, not are you sleeping well? It's how long does it take you to fall asleep? How many times are you waking up at night? I usually ask, are you getting nightmares? Then what's the total number of hours, and do you take naps? It's like really concrete questions with kids and adolescents, and even parents, when you're talking about sleep functioning. All right, we also take off medication. This is my part that I love in pediatrics because kids get better, yay! So for those pediatric anxiety disorders that are lifelong missions, their kind of distress or the intensity usually can go down with the SSRI, and you want to keep them on that dose for 9 to 12 months. That's when the year-long comes in. It's not from when you start the medicine, which is what all the anxious parents say. He's been on it since this date. I was like, no, we didn't get to a therapeutic dose until this date. So we start counting from this day, 9 months to a year. If you can go more than 6 months on that dose where they're actually are functionally fine, you'll start to get that neuroplasticity that retrains the brain to stop using that fight or flight pathway first. So that's why you have to keep dosing it until you get about 6 to 9 months. And then literally is when the brain changes start to happen.
Dr. Harris, we had a quick question just about sleep. How long is normal in terms of time to fall asleep?
Oh, I think it depends. Usually under a half an hour is pretty normal. If it's taking a long time to fall asleep, then I kind of dial into what's happening. If they're talking about it from when their head hits the pillow or when they start their bedtime routine, but also really the impairment from mental illness happens like, are you having racing thoughts? Are you like thinking about what happened that day and replaying it over and over in your head? Are you anticipating what's going to happen tomorrow? Are you worried about someone breaking into your house and killing you? Like what is happening during that time is going to be helpful. If it's a sleep hygiene, we are all very familiar with sleep hygiene, then that's the approach. If it's from, I can't turn my brain off, or I'm really scared of this happening when it's not accurate, then like it's okay to be scared if there is a reason to be scared. But if it's not accurate or helpful and is causing impairment during the daytime or having a hard time, then I would treat it with the medication if they're on the medication, if that makes sense. So about like roughly 30 minutes. But again, I sometimes don't listen to kids that are under 12 because they have no concept of time when they're falling asleep, how long it actually takes. And they have a hard time summarizing too, that kind of thing. But all right, if there's more questions, please let me know. Great question. So this is about how do you taper off. So if you've been on it longer than 3 months, even if you're on like Prozac, like technically Prozac, you don't have to taper. But if it's like a high dose, like 40, 60, 80 milligrams of Prozac, I usually do taper to see if the symptoms are coming back. So I'll go down like 50% pretty quickly with fluoxetine because it's so long acting. And then kind of hold off there for a month and see if you're getting a lot of relapse symptoms, or if the patient's like ready to use the skills to kind of combat the distress. And if it's not working, the functional impairment's coming back, we'd kind of gently go back up to a little bit more and just say, not yet, we can do it later. And, try again in like 3 to 6 months. For sertraline, which is short acting, you have to go a little bit more carefully, especially if they've been on it for a while, like over 3 months. You want to dial it down like a quarter, like 10 or 25% of the dose each time, and then give the receptors a chance to like reset. And the whole point is to not take it off so quickly that you have relapse of your symptoms and kind of ruin the whole timing process. So if you stop it too soon, the chance of it coming back is higher. And especially you can tell if a kid stops a medication about a month prior, I would start to notice if they're having more irritability, more impairment at school, more symptoms coming back. It's usually because they stopped it like literally 4 to 6 weeks ago, because it takes 4 to 6 weeks for the receptors to reset. All right. Treatment failure, big deal. Okay. So total, you've been on it at least 12 weeks from when it starts to touch your mouth. You do the maximum tolerated therapeutic dose in this range that we talked about at those slides with the graph, for at least 4 weeks. So you've been, and I said 12, but I meant 8. So you have to be on it for at least 2 months. But for those last 4 weeks, you're at a therapeutic dose. Let's say you get up to sertraline 200, actually. Yeah, sertraline 200. But if you could only tolerate it up to 100, that would still count as a therapeutic dose. Like if you go to 150 and like you have GI issues or something like that, it's just, or it's messing up with your stimulant, then we kind of drop it back down. But the maximum tolerated therapeutic dose for 4 weeks, if it is not remitting symptoms, it's a treatment failure. And that's when you dial it down and switch to a different SSRI. It's not a treatment failure if they've been on fluoxetine 10 for a year. That's like a dosing failure of not getting it to a therapeutic dose. Does that make sense? And if they have side effects, that means we're not tolerating it. Not that it's a treatment failure, it's just they're not tolerating the medication and they can't get it up to a therapeutic dose. But that happens often with like little kids who get too activated, and you have to wait to do the SSRI till they're a little bit older and they can handle it. But that's when I would talk about it being like a side effect issue, per se. So how much is too much? This is what parents ask me a lot, which is confusing to me because I don't really think about them being too much of these things, because I obviously have a selection bias and have kids and parents on like really high doses of the medication and they are fine. But I have seen where you get like apathy syndrome, where you kind of overshoot and your serotonin receptors are, then it kind of fits into the dopamine receptors, and then you kind of like drop. It looks like you're high on cannabis. So you're not, but it's like that, those receptors are getting hit. So your motivation goes down. You don't really have intellectual curiosity. You're like, I don't care if I'm getting C's when this is like a perfectionist kid. That might be a sign that it's overshot. So then you kind of pull it back down to kind of get rid of it. But the symptoms, and this is like explaining why it happens. I'm gonna like keep going just for the sake of time. But of the ones, the sertraline is probably going to be the least likely to have this happen versus sertraline, or I'm sorry, fluoxetine or escitalopram. And if they, yeah, but this is, it can happen, especially if you have more than one thing making it serotonergic. Sometimes even I've had it in kids that they get like, they start having symptoms of too much serotonin, like they get super sweaty or they're really agitated. They can have restless sleep. The ones that I think about, let me see if it's listed in this slide, where it's like too much is the sweating when they're sleeping or sweating all the time suddenly. I've had this happen with SSRIs and methylphenidates. It's been really interesting, but you know, phone a friend if that's happening and they can help you decide which medication to adjust if that's happening. But this is signs of serotonin syndrome. And just to think about it, I keep forgetting this because often with ADHD, you want to work on appetite induction. We use cyproheptadine often or periactin. And that actually is an interesting medication that also blocks serotonin. So if you're giving that plus an SSRI, be aware that you could be counterproductively managing two different things. So it can block serotonin activity. But that's helpful if you have too much serotonin. Other things, melatonin, hydroxyzine, atomoxetine. These are all things that should be very familiar in the pediatric primary care world. And the hydroxyzine, just like how you do it for eczema, it is like that 10 to 25 a dose every 6 hours or so. Do not give it every day because after about 2 weeks, it's not going to work. But it is indicated for pediatric anxiety. I often use this for school refusal because it tends to be less sedating than other antihistamines in this category. Melatonin, less is more. Happy to talk more if you need it. But then comorbid ADHD, some anxiety, some ADHD, the kids not tolerating the stimulants. So atomoxetine is a great option. Now we also have guanfacine ER, like the Intuniv, and clonidine ER, the Capve, but even the viloxazine or Qelbree these are all like awesome game changers when they aren't tolerating stimulants. Okay, so medicines with a psychiatrist, propranolol is really common. This is the thing that they use in dermatology for hemangiomas. So it's kind of like they give it to infants and it's okay. And it actually helps quite a bit, especially with situational anxiety for kids, like driver's tests or a big test that they have to do at school. But it's not going to replace the treatment that you would typically, like first line treatment. It's just more of like an adjunct. And to do it with a psychiatrist because they're not FDA approved in kids.
And Dr. Harris, I just wanted to mention, we're probably gonna lose some folks at 1 o'clock. So
okay,
if
I have
you
no
had,
idea what time it is. I am so sorry. Oh my
it's
gosh.
okay.
I'm
Any
gonna
other
stop actually.
questions
Yeah.
or things that you wanted to mention just
I am
before? I
so
know,
sorry.
no problem. I know it's a lot to cover in a very short
Yeah.
amount of time.
Yeah.
So I wanted to give everyone the opportunity to ask any questions before 1 o'clock hits, and I'll finish up with the some reminders and data that'll be in the recording if you do need to leave us at 1 o'clock. But any questions? Or Dr. Harris, anything else you wanted to mention?
No, I just left it on the last slide, which is the AAP supports too, for how to manage it.
Great, and we'll make sure everyone has the slides. As I'm going through the next few slides, again, please feel free to chat in any questions that you have. I'm going to start just because I know some folks are gonna have to hop off just with reminders for you. Unbelievably, we are coming to the end of another month. So I just wanted to mention, please be sure that all your providers are entering data after appointments. So make sure that on the iPad, you're entering that after appointments and it's all entered and up to date because we will be pulling down your December data. I'm sorry, your January data. Also make sure that all baseline data is entered. That was due at the end of December. So I've given a little bit more time. Some folks were finishing things up, but we are going to be pulling that down. And don't hesitate to reach out to me if you have questions. I'm happy to answer any of those. Either you can text me, call me, send me an email, whatever kind of works best for you. So just let me know. And also remember that I'll be sending out the email to get your denominator for January. So that will be you giving me your total number of appointments so that we can take a look at rates. So very quickly, and again, if you need to go, please feel free to go. I'll be sending these slides and the recording so you'll be able to review that. So we did separate the data this month into family medicine aggregate data and then pediatric data. We may end up combining those on charts, but for now we've separated them. As you'll remember, you receive your practice code, so you're able to look over in the table on the right and see kind of where you performed related to the average. So on data tool completion for the month of December, we're at about 61%. That means 61% of the time for family medicine practices, when you have an appointment between age 12 and 21, you are getting your data entered. We want to see that higher, of course, up around 85%, but that 61% is a great start for the first month. So keep working on your process. Make sure you're doing it all the time. Many of the other metrics will fall in line with what that metric is. So keep that in mind. If you have low performance on getting your data entered, everything else is going to be low. Because for those patients that nothing is entered, we have to assume that screenings didn't happen, lethal means discussion did not happen. So depression screening rate, about the same. Again, we want to see that up around 85%. This slide, and you have this specifically for your clinic, but this is showing the aggregate, shows you kind of the results of the screening. So you'll be able to see that roughly 79% were no risk, 16% had mild risk, and then we had 5% with moderate. Suicide screening rate, a little bit lower than the depression screening rate, around 55%. Again, for most of you, this is a new screening that you're just getting into practice. So again, getting into a consistent pattern of making sure that is completed at all those appointments, just like the depression screening. And this will show you, again, your results. So you have 88% at no risk, and we're having 12% with potential risk. Lethal means discussion rate, a bit lower, 42%. And again, we want to see that up around 85%. This is indicating that you're having that discussion at all of those adolescent appointments. Resources discussed and or offered. And I do want to mention, if you talk about the resources and offer them to a family, you select yes for this question, even if they don't accept them. So the answer is not based on if the patient took the resources. It's just that you talked about them, offered them to them, and that's what you would code as yes. Same thing with the lock boxes. If you offer the lockbox and they do not take it, you still would answer that as yes, that you've offered it. I've also been reminding practices, you can offer the lockbox to everyone that's coming in for those adolescent appointments. They don't have to indicate that they have a firearm in the home for you to offer the box. You're more than welcome to offer it. I know some of you have said, if we do that, we would go through boxes like way too fast. We can deal with that if that should happen, but just know you're not limited to only offering those to families who indicate firearms. Treatment plan initiated or continued. This looked great. It was a very small N, but this basically says when you determine based on the screenings that a patient is at risk for depression or suicidality, that they have a treatment plan in place or you initiate a treatment plan, but you're doing something, you're taking some kind of action. And then these next slides are related to the family feedback survey. So that survey that families voluntarily complete after the appointment, roughly at about 47%. We think that's actually a good rate. We usually see it right around 50%. So that's kind of what we expect. Lethal means discussion rate. So all those families were indicating that yes, lethal means was discussed with them. Same thing for resources. And again, we were at 0% for anyone other than the physician talking with them ever about this kind of risk. So just highlighting that message. Again, I know it's a small N, but highlighting the message that they're not hearing this from anyone else. So pediatric data, we have a lot more practices. Again, your codes are over here on the side. If there is a blank, that is a practice that added on some providers in December. And so we really weren't looking at their data. So around 70% completing the data tool. That's wonderful for the first month. So please keep pushing. We want to see that get up around 85%. Depression screening rate was at 69%. This shows the results again in aggregate. You can look at the coding. Suicidality screening rate was around 56%. Again, a bit lower than depression. It is new for most of you. So again, we want to keep working to get that to be just as consistent as your depression screening. And then also showing again your rates. So really in that first month, you identified roughly 29 kids on the suicidality screening. Lethal means discussion rate. Again, I think this is very good performance for the first month at 66%. We want to keep working to get that up. Resources at 61%, and your lockbox offer rate was at 43%. Treatment plan, and again, 72% is a great number. So just keep in mind that if you are identifying patients in need of a treatment plan, that you're indicating that that started. And then again, family feedback survey, very similar. Of course, we had a larger in here, but we're around 46% of the time they're completing that survey, indicating almost at 100% that you did discuss lethal means, that they did receive resources at 87%. And this one is around 27%, indicating that anyone other than a physician talked about risk. So I tried to go through that really fast. And if anyone has data questions, because you all have received your individual practice data, please let me know. I'm happy to have a chat or answer emails. Let me take a look at some of the comments. 70% is great. Again, great performance overall, especially for the first month. And as Dr. Denny mentioned in the chat, if you're having any problems with implementation, office flow, we are always here to help you work that out. Dr. Harris mentioned, I wonder what the practices are doing to get 100% of their families to respond to the survey. So not 100% responded. Dr. Harris, that might have been confusing on the slides. About 50%. Oh, you're saying that some of the practices did. Yes, I see what you're saying. Great point. I think that that would be really something great to hear from the practices. If you are a practice who's getting a lot of families to answer those surveys, let us know what you're doing. Feel free to send me an email about what you're finding works, and I'll share it with the whole group. Any questions for those who are still on the line? Please feel free to unmute or chat in, and I can unmute you if you're not able to get yourself unmuted. And I know we're over time. I apologize for that, but thanks for those who hung around.
I think, Kristen, somebody just asked how they know what their code is.
Is that what you were wondering? Or Dr. Tarai, you should have gotten your code in an email. Or are you saying who were those super high performers with getting family surveys completed?
No, I guess I'm just looking for the email with my code. I'll try to find it.
Okay. Yep. I can resend that to you as well too.
Thanks.
When you got your individual December data, it was noted in there, but I can resend that to you too. So you know that. Any other comments or questions? Feel free if anything comes up after the call, either about Dr. Harris's presentation or data. You can always send me an email if questions come up, and I'm happy to answer. I'll be sending out a follow-up email with all the slides, recording, and then be sending those data reminders for January. Dr. Harris, thank you so much again for such a wonderful talk. I know we could have you talk for like half the day and still not get through what we need to, but we really appreciate you joining us again for this collaborative.
Yeah, thank you for working on this. This is amazing. I love this program.
All right. Thanks, everybody. Have a great rest of your day.